Good evening, I'm Chris Berg. As always, thanks for joining us. Tonight's point of view topic: how does the Affordable Care Act, i.e. Obamacare, impact you and your family, especially after President Obama's comments today? To help us answer that question tonight is the CEO of Blue Cross Blue Shield of North Dakota, Paul Van Ebers, also Dr. Spencer Berry, also a state senator here in North Dakota, and the vice chair of the Health Care Reform Committee. Gentlemen, thanks so much for being here. I want to start obviously with you, Mr. Van Ebers. So he basically, what I hear is he's going to tell the state insurance commissioner, hey, you got to go back to your insurance companies and tell them to basically reinstate these policies. So from what you heard from the president today, what does that mean for the 31,600 Blue Cross Blue Shield members that have gotten a letter saying, hey, we're canceling your insurance?
Thank you, first of all, Chris, for having us here today. And obviously, this is a big announcement that the president made today. We're still absorbing the announcement a little bit. Certainly, our view is that we never really wanted to cancel these products. And so on that level, we're happy to have the opportunity to let people continue to have the plan that they had. We need to understand the details a little bit more. There are going to be some administrative challenges of making this change, and we need to understand how it will affect the insurance marketplace that's been set up under the law.
And I guess that's my question. You've already sent out these cancellation letters. I'm assuming you've already lost that insurance pool. Is it even possible? I mean, here's a guy who's a president. He's not a CEO of a health insurance company. Is it even possible to go basically and reinstate those policies?
Well, we're certainly going to do the very best we can to serve our customers, which is what we always try to do. And as I said, you know, we would have just as preferred not to cancel the policies to begin with. We're going to have to figure out the administrative issues and just deal with them.
Which is going to also increase the administrative costs, which means I get to pay for those, correct?
Well, it is going to be extra work. The Affordable Care Act has given us a lot of extra work to do. But it is the law of the land, and so we're going ahead and doing it. And this announcement today will respond to that as well.
I'm going to get to the name of this bill in a moment, the Affordable Care Act, maybe the biggest lie of this entire thing. But Dr. Berry, I want to start with you here for a moment. You're a legislator. You understand the legislative process. I'm going to be fairly crass here because I'm upset about the way this thing has gone down. Here you've got a gentleman who's an executive stepping in today. He's already changed the one-year mandate for the companies, which, oh, by the way, I thought was a legislative thing. Now he's going to come in and go, oh, now I'm going to make companies and change this law again as an executive, not through Congress. Is that even possible?
Well, those are things they're going to have to determine up on Capitol Hill, and obviously you're going to have differing views depending upon which side of the aisle individuals come from and where their point of view is. The reality is, going back through the legislative process would be very difficult to change this particular law because, for obvious reasons, one of the reasons the law came out the way it was, which was admittedly flawed on both sides would recognize this, was based on the fact that they could not bring the law back from where it originated because they didn't have the votes to bring it back out. So, because of some changes. So this law was obviously very contentious. It was passed obviously in a non-bipartisan fashion, and so therefore that's created a lot of the problems. Hopefully both sides will be able to get together. You know, I always like to say, I've heard it said before, I believe it's very true, that it's never too late for realism to trump idealism, and so we need to put this into place so that we can affect and help the American lives.
A couple questions for you, Mr. Van Ebers. When did you know that 31,000 plus were going to lose their health insurance?
We've been analyzing this as it went along, and you know, we've known for at least several months what the size of the issue was going to be. Now, one thing I should say is that a significant percentage of those people would have a comparable product available. Some would not, but many of those customers would have a comparable product available under the new products required under the law, but some wouldn't and would have to buy higher benefits, and in some cases that would be at a higher cost.
Now, you referenced this bill early as it's been called the Affordable Care Act, but I think the irony is that through a study recently done, North Dakota specifically shows that the average person's premium is going to go up 40%. Is that accurate?
Well, we have changes in benefits. So in many cases, people are receiving higher benefits for the premium they're paying. The Affordable Care Act does require somewhat higher benefits than some of our customers have been experiencing. So that increase is built in. And then there are year-over-year healthcare inflation increases, which we are very concerned about.
But I think the big question is this, and let's be frank. I mean, so my insurance premiums are going to go up 40%. We know that this is all about, and maybe I should ask this the better way, is this a way to basically just wealth redistribution? You've got young people now being forced on this thing that don't want some of these higher coverages that you've talked about. Are they just trying to basically redistribute wealth through this situation?
Well, one of the concerns that we've had with the law, and we continue to have that concern, is whether enough young people will sign up. It is a concern of ours. We do feel we're in a better place than some other states, because in some other states, insurance companies have used a bigger spread in pricing from young to old than we have, and so some of the increases here will not be as big as in other states.
But on the flip side, don't you think most young people go, okay, I don't need health insurance, I'll just take the $95 tax, if you will, and not get insurance at all?
We are concerned about that. Now, many young people do also have low incomes and may be eligible for a subsidy on the exchange, and so we would certainly encourage everybody to check that out. There will be some young people who are not eligible for a subsidy, and then it may be difficult for them to justify it.
Two things for you, Dr. Berry. One is, if these young people do not go on this exchange and end up just getting the tax, as they're calling it, does this thing basically implode on itself?
Well, it's very difficult to justify the finance behind it. The whole idea of the Affordable Care Act is to bring more people into the pool, basically more lower risk individuals, which will in fact help subsidize those that are more sick and that require more health care. So the reality is, if we don't get those folks in the pool, and that's a major concern right now nationally as well as in our state, if those individuals aren't in the pool, yes, it's going to be difficult financially for the Affordable Care Act to stay solvent.
Last question for both of you, and fairly quick answers. Looking back now, should we have voted to implement our own state exchange in North Dakota?
No, I don't believe so. I think that ultimately it was the right decision not to, from the fact that based on the way the law was written, when the federal dollars stop coming in, which is to be very soon, within a year or two, any state that has an exchange that's up and running will be responsible for their own at that point. So that state would be on the hook regardless of what happens going forward, and obviously that's far from settled. Now, for those states that have put those in play, they will be required to jump in and take over the cost of that, whereas at any time after this gets going, if it becomes manageable and becomes something that is practical, North Dakota has that ability to step in and take the management.
Your thoughts on that? Should we have created our own state exchange?
Well, you know, Blue Cross Blue Shield of North Dakota supported a state exchange, and we still support that idea. Some of the state exchanges, many of the state exchanges are actually operating better than the federal exchange, but the cost is a concern to the state. We think there would be opportunities to share the technology with other states. But the key thing that we want for North Dakota is North Dakotans making the decisions about how this thing is going to be run. And that's why we supported a state exchange.
Stay with us. When we come back, we're going to talk. We took some of your questions from earlier this week. Also, what can we really do to start to lower the cost of premiums here in North Dakota? As always, be sure and join our conversation. Head over to our website, 630pov.com. We'll be right back.
Come and get huge savings during the holiday sale at Oak Express. All dining room groups are on sale. Every one. Save 20% on all
the commenters alone. They do not represent the views or opinions of Valley News Live, our parent company, or our advertisers.
Welcome back. We're talking about the Affordable Care Act with the CEO of Blue Cross Blue Shield, Paul Von Ebers, also Dr. Spencer Berry, the Vice Chair of the Healthcare Reform Committee here in the state of North Dakota. Thanks again for sticking around, guys. I want to get to a quick question that came in a while back as we've been having our healthcare series in America. A woman wrote in and says, hey, my brother makes $18,000 a year. His premium under Obamacare looks to be close to $600 a month. He can't afford it. He's going to qualify for the subsidy, which is great, but how does he get it?
Sure. Well, first of all, the only place you can get the subsidies is through the exchange or the federal marketplace, which, as we all know, has been having some problems lately. However, this person does have through March to sign up and get the coverage. We hope, just as the federal administration hopes, that this website is going to be working better as we get closer to the end of the year, So that's where he needs to go to get his subsidy.
And I think the question is, so if you're going to base this off my income, I can't pay $600 a month making 18 grand a year for a year and then get my subsidy. So am I subsidized monthly, or how does that work specifically?
Yeah, it's really an advanced tax credit, which will help pay on an upfront basis. The person will only have to pay the portion of the premium that is not subject to the subsidy. So it will help people afford it right from day one. They will pay just a percentage of the premium that is not covered by the subsidy. So we would receive some money directly from the federal government and some money directly from that individual.
Got it. So he's not going to have to pay the full $600 per month.
Right.
Thank you. All right, let's move on to the cost of healthcare. You guys know as well as I do, 17 to 18% of our GDP goes to what I call disease management in this country, $2.5 trillion a year. If we don't get this cost curve under control, it's just not feasible for our country to stay on top of things. So I want to move into a place where, why can't we begin to incentivize and actually talk about health? I'm tired of talking about disease management. When are we going to have this health conversation? Dr. Berg, I want to start with you. You run a company called Medical Weight Loss Specialists. You're doing some great things over there. How do we begin to help people understand the value, the power of health, and what that's going to mean to bending the cost curve in America?
Well, Chris, that's the key issue, is bending the cost curve. That's what initially the Affordable Care Act was also designed to do, or supposed to do. The reality is it's health insurance reform, it's not health care reform. What we need to understand is that 75% of our health care dollars are spent on management of chronic disease. And the vast majority of chronic disease has to do with lifestyle. It's lifestyle related, that we can modify it or sometimes totally prevent those chronic diseases. How so? Things like diabetes, high blood pressure, heart disease, stroke, many cancer risks, cholesterol. A lot of this is managed through learning patients how to manage body weight, help them to become more active in their lives, obviously the discontinuance of tobacco.
Here's what I want to get to, Dr. Van Ebers. Safeway is doing this. They've got their own, obviously, health insurance in their own company. What I want to know is why you're not doing this, why other companies aren't doing this. Here's what I mean specifically. I go out and I eat kale, and I drink water, and I'm not drinking beer and eating a bunch of Doritos all the time. So I've got a certain BMI, I've got a certain body fat, I've got a certain cholesterol level that hits parameters. Just like car insurance, if I don't get in an accident for a year, I get a rebate, I get a discount. Why can that not help in health insurance? Because I'm tired of paying for the guy that sits around and eats Doritos and drinks beer all day.
Right, right. And, you know, we do offer a number of programs to offer incentives for healthy behavior. And there are opportunities under the Affordable Care Act within limits to provide either lower premiums or other types of incentives for people who engage in healthy behavior. Unfortunately, under the law, those are somewhat limited.
How specific? Because I remember even before when we had this conversation, well, Chris, we can get a $25 a month discount on a gym membership. I'm like, come on, that's not real incentive. So what do you mean when they're limited? Limited how specifically?
Well, they're limited as a percentage of the premium. In other words, they can't have a value higher than a certain percentage of the premium. And that gives us some limits. There's also an ability to vary our premiums based on whether somebody's a smoker or not. But some of the rules around those tobacco discounts or non-tobacco discounts are also somewhat limited and difficult to implement. So we'd like some loosening of the law in terms of what we're allowed to do in terms of the incentives. But we agree with you, and we also agree with the idea of managing chronic disease better, and that's why we're incenting doctors in order to be able to provide that additional care for people with chronic disease.
I want to get your thoughts on both of this. So I read a stat where I think it was since 1999, the healthcare industry spent over $5 billion lobbying Congress, where the oil company in the same time frame was about $1 billion. Should that money be pulled out of D.C. to help the American people and make this thing about health, not disease management and pocketing, money in medical device manufacturers?
Well, lobbying in government is a huge issue in total for everybody. But we certainly agree that we want to start paying for results in healthcare. And I think that's what all of us want. If we go to a doctor or a hospital, we want results.
Is that possible with all the lobbyists greasing palms in D.C.? I mean, I think it's great to talk about, but is that realistic with all the lobby money?
Here in North Dakota, one of the great things about being in a smaller state is that people can really sit down around a table and solve problems, and Washington doesn't have to determine what we do here. So we have very good conversations going on right now with the major delivery systems in the state around how we can change the way we pay for health care and how we can support each other to help individual consumers live their lives in a healthier way.
Yes or no, does this law need to be repealed?
You know, I think it's unrealistic that it's going to be repealed. So what I'd rather see is that we make some incremental changes, and that's going to require that the political environment in Washington change.
I've got 60 seconds, but talk to me about the lobbying. Anything else you want to share, Doctor?
Well, obviously, as mentioned, the lobbying is there. It's going to stay there, obviously, to some degree. To the bigger issue, I think, is, again, here in North Dakota, we're able to do things with each other. And if we clearly communicate to patients at the primary care level, effectively talk to them and get them to realize and understand that they are the most important factor in their health. They, personally, the decisions they make, the things they decide to do, the things they decide not to do, how they go about their lives, that primarily determines how their health will be. And I have found that when you engage patients in that, which is what I do every day, they understand it, they learn how to manage that, and they're empowered.
And Dr. Berry, that's the key thing you and I talked about yesterday. You said, hey, Chris, the number one way to actually start to bend the cost curve in healthcare, don't use it so much. And how do you do that? Live a healthy life. To both gentlemen, thank you so much for being here. I really, really appreciate your time. I hope we can continue this conversation in the future.